Thank you so much. I'm humbled to be in this congregation. I must say thank you to HuQAS, because the first time I attended them, it was Nairobi at the headquarters. That was 2018. Then the next time during the pandemic, we were on Zoom, and I can say I'm a regular member, and this is my third time. Thank you so much for loving Uganda and bringing us here. So as per my name, I'm called Dr. Harriet Nakigozi. I hold a PhD in Public Health Policy and Global Health from USA. I have a master's degree in Biomedical Laboratory Science and Management of Makerere University. I have a bachelor's degree in Biomedical Laboratory Technology of Makerere University, as well as a diploma in Education, Biology, Chemistry from Kyambogo University. I'm registered with Allied Health Professionals of Uganda, and I'm licensed. That's what I can say. So I work in CPHL, which is Ministry of Health, and I do coordinate the performance improvement, as well as a program technical officer for the non-communicable diseases. So with this, I'm presenting one of the implementation studies we did on cervical cancer, and it is entitled The Prevalence of High-Risk HPV Genotypes and Associated Factors Among Women Living with HIV/AIDS in Selected Public Health Facilities or facilities in Uganda, and we had 15 of them. So, as you see, we were a team of senior lab experts, me being first. We had Dr. Susan Nabada, who is our commissioner. We had Dr. Achora Carol, who is a pathologist. We had Nabagala Annette, who was our program officer. We had Mudanga Harriet, Kanamwanj Ben, Dr. Mtunji Gerard, who is also our assistant commissioner for non-communicable diseases. We had Dr. Akia Charles Oyo, who is our commissioner for non-communicable diseases. We had Mukunya David, Dr. Mukunya David from School of Public Health, Dr. Bate Charles from Makerere University, Dr. Andejo, still Makerere University, and we had Karin Banji from Swedish Institute. So it's under publication, that's why we have that. What we wanted to bring to the house is the background of cervical cancer. So ladies and gentlemen, we are having a timely bomb, and as synergies here, because we are brought together to see how we can synergize and strengthen our supportive system in health. And this is directly addressing the Global Sustainable Development Goals, Agenda 2030, and this one is directly targeting Agenda the SDG 3, Good Health and Well-being. Cervical cancer is the leading cause of mortality among Ugandan women, according to Global Can data and WHO 2021. So if you are here as a woman, I want you to pay specific attention to this. Uganda has 1.4 million people living with HIV, and among them, 1.2 is aged 15 to 64 years, according to a UFIA study. And among those mentioned, we have 7.6% among the people being female, and 4.7% of the HIV positives being male. You see, women are taking a lead. So women living with HIV are at a higher risk of having cervical cancer, what we call cervical dysplasia, compared to other people who are negative or not having HIV. Actually, they mention, according to the research, it is 3 to 5 times. And that is according to the WHO. So in 2015, there was a guidance given by WHO, and it recommended testing for high-risk human papilloma virus to be incorporated into our services. So, however, in Uganda, we are still seeing that the testing is not yet fully institutionalized. In Uganda, high-risk HPV has been institutionalized in HIV treatment guidance, but its testing coverage is still low across the country, much as we are having that burden. Like as you can note in that line, there are 6,959, which is accounting to 35.7% of new cases of cervical cancer every year, which is being reported at Cancer Institute. So the objective of this study was to determine the prevalence of the key high-risk HPV genotypes, and those are 16, 18 to 45, and other high-risk HPVs, and the frequency of those HPV genotypes in the selected places, looking at also on the associated risk factors which could or might cause those HPVs to be existing in the samples. We set out a method which we called methodology, and this one, as I've told you, it was purely an implementation study in the 15 selected public health facilities. So a cross-sectional descriptive study was conducted using mixed methods in the selected facilities between August 2020 to May 2021. These facilities were selected depending on their volumes. They were high volume sites, and they had patients who were active on ART. We enrolled 5,856 female participants who were already having their ART treatment, and these ones we were specifically targeting those aged between 25 to 49 years. So participants were requested to consent before collecting their samples, as it was one of the guidance we had to follow. So participants' demographic data was collected using a standard questionnaire, and HPV testing was done using GeneXpert at 12 sites, and 3 sites referred their samples to the Central Public Health Laboratory for the centralized testing using the Hologic Aptima PCR machine. 3,824 participants were from the 12 health facilities. Those ones were put on the DNA testing on the GeneXpert. Then 2,032 participants were tested using the Hologic Aptima PCR machine. So that is our sampling we did. We had Kabale, Hoima, Gulu, Lacho, Masaka, Mbale, Mubende, Mbarara, Fort Poto, Moroto, and Naguru. And the Hologic, we had Chenjojo General Hospital, Lira, Jinja Regional Referral, and with Jinja Regional Referral, we had the hospital itself and then the TASO, because we are based on the ART clinic. So this study received the approval from the Higher Degree Research Ethics Committee of Makerere University and Uganda National Council for Science and Technology, and it followed the Ministry of Health guidelines and procedures. With the patients, as I told you, that they had to give us consent before we collected these samples from them. Data analysis was done in entering the data into Microsoft Excel sheet and analyzed using the SPSS statistical software. Bivariate and multivariate analysis was conducted to determine the risk factors which were responsible for the occurrence of this high-risk HPV. The results, so among the genomes, we had HPV 16, which had the lowest prevalence of 262 patients, accounting for 0.17% compared to others. Of course, I've told you that we had to enroll 32 on the Hologic, and then 3,824 were on the DNA testing, which is the GeneXpert. So all those, when you add them together, they gave us a total of 5,856 patients who qualified for this study. Majority of the patients were aged 36 to 49. They were multiparous, meaning that they had given birth to more than 1 children. Then they also had been married. So among the positives, we had 2,006 of them, and that accounted for 34.26%. We had 19.44% of the positives which were identified using the Hologic, that was the centralized testing. Because I've told you, for it, we had it at CPHO, and for it, it was RNA based. Then we had the others being tested on the GeneXpert. So that is the table which is illustrating what I've been talking in many words there. We have from age 25 to 35 and then 36 to 49. Remember, our target group was from 25 to 49. So that was the variation there. We had those who had one child, whom we call prime or primipalas, meaning that they had got or given birth to one child. Then we had those who had multiple births. We had those who had one partner. Then we had those with more than one partner, according to the distribution, plus those who had sex when they are still below 16 years, and those who had sex after 16 years. So generally, we had 15 high-volume health facilities being targeted. We received 5,856 participants, and all of them were female, because it is the female who have the cervix, not the men. So that's why we call it cancer of the cervix. 4 selected high-volume sites were seen, and among the risk factors we selected or we saw, which were trying to be responsible for what we are talking about, was parity. If you have produced one child, you are at a less risk compared to the person who has produced 2 or more children. Then, number of sexual partners. Those having more than one partner were at higher risk. Tobacco smokers, still it is another risk factor, just as in HIV. We had initiation of sex at an early age. Still we saw that from the people we had, those ones who had initiated sex below 16 years or early age were at more risk compared to the other ones. So that is the same distribution I was talking about. The hologic, we had 394 samples, giving us 19.39%. Then the GeneXpert, we had 1612, giving us 42.15, accounting for that. So the risk factors in visual, you are seeing them. The positivity rate, I told you we had 2006, and accounting for 34.26 out of the total sample we had. Then the risk factors by distribution: tobacco smokers, multiple partners, early initiation of sex, and then multiple parity. So that one again was another chart and bar graph to introduce us to the different genomes. We saw HPV 16. The red means the GeneXpert, and then this other one means the hologic. Then HPV 18 to 45, and then other high-risk genomes. In conclusion, the prevalence of high-risk HPV genomes among HIV-positive women attending ART clinic in Uganda was high. Other high-risk HPV genome was the commonest compared to the 18 to 45 and HPV 16. And having more children, multiple sexual partners, smoking tobacco, and having sex at an early age were the most predisposing factors, because they were identified to have a p-value which was less than 0.005. Recommendations: there is a need to scale up HPV molecular testing for higher risk HPV genomes across the country by integrating it into the routine health care to reduce on the incidence rates of cervical cancer in Uganda. Because the biggest problem we have, by the time they tell you that you have cervical cancer, you're already in advanced stages, and there is no treatment for you other than palliative care. Negative HIV women need to also be tested for high-risk HPV genotypes, or what we call the oncogenic strains. Further research or a nationwide study needs to be conducted to cover all the facilities which we didn't reach in. Because Uganda, we have over 1,000 or more of these health facilities. And because of our resources, we're able to reach only 15. The limitations: we had limited funding and there was lack of enough HPV supplies. This study has already impacted both, as we are saying, locally, regionally, and internationally. And that is one of the awards I received in managing innovations for sustainable health for senior leaders. And we are targeting Ministry of Health practitioners. And I was able to be with my colleagues from Congo, from Somalia, Uganda, and then the Tinkley Solutions, which was based in Sweden, plus Karolinska, who awarded us that certificate. Then still this impact, the second impact is that it has received some support to be supported by the Fogate International Center of the National Institute of Health and award that to be published in the peer review journal. I acknowledge the sponsors for this. There was Makerere University, there was Karolinska Institute, CDC, Department of Global Health, University of Washington. There was HuQAS, which has allowed us to present this. We had NIH, we had Clinton Healthcare, and then PEPFAR. For God and my country. Thank you.
I took interest in your presentation because I'm a woman, and what you were presenting directly affects me. So I was following you in your data analysis. You said that the factors that you were considering to be significant, they were being looked at when they had the p-value of less than 0.05. And also in your analysis plan, you said that you used bivariate and multivariate regression logistics. Now, my question is, I would like to know if all the factors that you assessed, of course, the factors that are contributing to the prevalence of HPV, all the factors that you assessed at the bivariate level, they were the ones that you pushed them to the multivariate regression level, or if there were only those factors that turned out positive at the bivariate level, that is having the p-value of less than 0.05 at the bivariate level, were those ones that you took for multivariate regression, that at the end of it all, it led you to the conclusion that the factors that mostly leads to the prevalence of HPV is early sex below 16 years, multiple parity, multiple sexual partners, and the others, as you mentioned. Thank you.
I want clarity on the parity, how it exposes, or people with the multiple parity had the higher chances of getting HPV, but through which method of delivery? Is it cesarean or the normal vaginal delivery?
My name is Obiageli. My question goes to Dr. Harriet. I would like to know why your study was centered on this age group, 25 to 49. Why did you choose HIV/AIDS positive patients? The factors you concluded that are the high risks, that have high risks for the HPV, you said multiparous women, those that smoke tobacco, those who have had sex below 16, and okay, so I would like to know, I don't know if your study has this included, but how did you come to this conclusion, and how do these factors, how do they expose women to HPV, these factors you listed? Thank you.
Good morning to you all. My name is Brenda. I work with Makerere University Walter Reed Project. in their paper program. Thank you, Dr. Harriet and Mr. Wambale, for those presentations. My question is directed to Dr. Harriet. In our region where I work, we operate in Mukono, Kayunga, Buvuma, Buyukwe districts. We've had challenges of stockouts of the HPV reagents. So I want to know what strategies you have put in place for that, because this program has been introduced to those public facilities, but you have supplies for 1 month and the next month they are gone and there is no plan. Right now, all the facilities are out of stock in that region and we have not got a way forward. Yet the burden is high. We have very many HIV positive patients, women, who require that service, but currently it's not available. Thank you.
Yes, thank you so much, Joshua, and then Dr. Harriet. My name is Kimera Enos. I'm a lab technologist and quality officer for Rukunyu Hospital, Kamwenge district, that is Midwestern Uganda. I am really concerned, and these issues have always come out. I believe research is done to inform policy, also to inform other decisions that are made. This goes directly to Harriet and also indirectly to some of us who could be here and at policy level, especially CPHL. In our government settings, we have referred samples through the hub system. When they end up in the government facilities or public facilities, you can take more than 6 months to get results, especially the pathology samples. We only get relieved when you use a private setting like Lancet and other labs. My question to all of us, and specifically to Dr. Harriet, is after the research that you conducted and also now an eye-opener from Joshua's research, at strategic level or at CPHL, which plans do you have to help the population? Because it looks like, or it is true that cancer is on the increase, but the diagnostic process seems not to be taking us anywhere. How are we going to help our population?
Good morning. My name is Isaac Ogwal. I work with Nakigozi Hospital. My question goes to Dr. Harriet. One, I would first want to know whether there is a comparable sensitivity, level of sensitivity or even specificity between GeneXpert and Hologic Optima that you used. And then two, still to Dr. Harriet, I want to know whether there is a step they are taking forward to engage the Ministry of Health to make sure that the accessibility of these screening tests are really up to the lower levels, because most of them are available at private facilities. They are very expensive for the population. That's why you see most of the people end up at Uganda Cancer Institute when they're already at stage 4 or stage 3 of the cancer, which is now at its worst. So how are they engaging the Ministry of Health to make sure that these things are available and cost effective?
So this is an eye-opener to all of us that we need to work together. You might have the money and I don't have the money, but I have the skills and we can work together. Is it true? Because we've seen it in COVID. The private sector has supported the MOH. Where things could not go on very swiftly, they have come in, and for us we've provided technical guidance. So I call upon everyone, like Achan has been concerned, women, you must be concerned, because this cervical cancer does not respect whether you are an MP or you are a farmer in the village in Ibundibujo. It all affects us much as the same way. That's what I can tell you. So we are looking at, when I look into the questions you've asked me about why I considered these 4 factors other than others, we had over 8 factors, including education, age, occupation, marital status, plus those 4. But when we did, that was at univariate analysis. When we ran the model at bivariate and multivariate, these others didn't seem to make significance until we said we do them bivariate. The bivariant, we got some, and then they were finalized in the multivariant analysis with a p-value. Some were having 0.001 to 0.02. But because of the, the science, p-value must be less than 0.005 for it to make meaning. If it is above, you ignore that and look at that. So that's why we ended up with those ones. Then someone wanted to know the parity, how it affects. Parity means the number of children you've given birth to. We use, like I can tell you, like during delivery, the force which is exerted on the uterus, because this cervix is just a part which is referred to as the mouth of the uterus. So the more pressure you exert to it, the more it gets risk, or it is more risky for it to get some of these opportunistic infections. Am I making sense? Because you can look at someone who has given birth to 1 or 2 children. Those ones, they are not at a higher risk than someone who has given 12 birth. So you realize that there is a lot of pressure, there is a lot of force which has been exerted to the uterus, and it is not able to control itself. And in the end, when it gets this infection, because it's a sexually transmitted infection, it is men who transmit these. But for them, because they don't have the cervix, they always transmit to the cervix. When they go on playing sex with different partners, that is when they are able to bring these problems to you. And always we call them carriers. But for them, you never find them having these problems like us. So about the community, there is a plan, as Dr. Manji mentioned, that we are strengthening the laboratory services through the regionalization approach. It has been recommended that we need to strengthen these lower units. We have the Health Center 3s, Health Center 4s, and cervical cancer. And because of this study, we have also included it into the regionalization programs, because earlier we did it in the regional referral hospitals, but because of the need, we've gone to also the district hospitals and some health center 4s. My prayer is that if there are willing Ugandans, collaborators, and international participants of this conference who are willing to partner with us to work together for the good of our country, for the good of East African community, we are ready, because this is still a challenge, not only to Ugandans. Because when you look at the global report, cervical cancer is running number 4 in USA or globally. Much as in Uganda, it is the leading cause of cancer, death among the women. So someone wanted to know about the age bracket, why we went to the 25 to 49. From research or previous studies, it has been noted that cervical cancer or HPV takes 10 years in your system, because you remain asymptomatic with no signs, and it is after 10 years then realize that you have these signs like bleeding, like having pain during sexual intercourse, having a fishy smell or odor from your private parts, and others. So by the time you get it, by 25, because our people are sexually active, they get it at 15. But it remains dormant. It remains eating. There's what we call the pathogenesis. It remains eating. 5 years, you might be still okay. But you begin having those cyan changes. Cyan 1, cyan 2, cyan 3. That language is mainly known by the pathologists. That's why we had them on that team to correlate our study. So by the time we know that you have, or by the time these symptoms come, some of us were already in the late stages, and they are always reported in Cancer Institute. But because we work hand in hand as Ministry of Health, we're able to access that data. So I call upon all of us to strengthen the primary health care. In the community, whether you have money or not, trust me, you have a person who is reliable to get this if you are not tested. So again, maybe I can also comment on that. we still have another method which is commonly used, visual inspection with acetic acid. It's a clinical procedure. But as laboratory, we've seen that we always get false positives. Someone comes with VI negative results, but when you screen them using the HPV DNA or RNA, they're having the lesions. They're having, and they can progress easily. And yet when they test with HPV DNA, they can take 5 to 10 years because it is highly sensitive compared to other methods. So why HIV positive patients? Uganda is a resource-limited country. And when you look at what has been presented, ladies and gentlemen, right from yesterday, we are still struggling with the communicable diseases, like the HIV, TB, malaria. We have these non-communicable diseases because right now they are accounting to 35% of our population. And also the viral hemorrhagic fevers, like the Ebola, Crimean Congo fever, and others. And we are not alone. Our friends can tell us, Kenya, Tanzania can tell us, Sudan can tell us. So which means for us to have a benefit where we put $1, we must make sure that we first save this HIV, because a lot of work has been done in the HIV, and from researchers or from other studies done in different countries, they have a higher risk, 3 to 5 times to get this cervical cancer compared to the normal population. But that one doesn't take away that an HIV negative person can also get cervical cancer. But because we have limited funding, we have little resources, that's where we had to first capture them there. And these ones we've been offering visual inspection with acetic acid. Then about the factors, multiple smokers and sex below 16. When we ran our analysis, those are the factors we saw significant, and we were able to raise an alarm on them. And probably when we target such factors, they can help us reduce on the incidence and the burden. From Brenda, yes, there is usually a challenge of stock out, as I told you, that it came as an implementation study. We had a one-off funding. Though, like when the results were got, PEPFAR took it up to see that we save the HIV patients. But we are still struggling. That's why we call upon partners. NMS is the sole distributor of this. And anybody who can be able to support Ministry of Health. We cannot say that it's none of our business. Because you have a wife, you have a daughter, you have a sister who might end up having this. And it might be late to save the situation. Then, ENOS, research is done to inform policy. Hub system, samples take 6 months. I'll also call upon Annette, because she's directly involved into this. But what we've tried to see, that we put up the LIMS, Information Management System, to also be integrated in the pathology lab. Because we don't work alone as Ministry of Health, but we do work with different partners to make sure that we improve the service to the patients. So, Annette, are you in the room? I'm going to give you a chance to talk on that, because she's part of my program team.
Thank you, Dr. Harriet. Actually, on my desk, Madam Navagala Annette, National Coordinator for Pathology. Probably you give your comments. Joshua to his questions. Where is Madam Annette?
So as Annette is coming on the podium.
Please come in front.
Yeah.
Yeah.
So accessibility of these tests is still low at lower facilities. I can agree, because we have limited supplies. We cannot work in isolation. That's why we are calling upon chem labs. We call upon other distributors to come and we partner together. Then the level of sensitivity, we noted that the Hologic Optima had a higher level because it is RNA based. And all RNA are better or superior than DNA. But because we had integrated the Gene Expert platforms, and in our country we have over 296, that is why we had to first prioritize the DNA testing to be able at least to reach those lower facilities to provide a service. But RNA is superior, and for research purposes, it has been used. Thank you.
thank God for the ICT now, and also thank God for the laboratory. With the lab team, I want to tell you people, the lab is playing over 80% in cancer prevention and control. This is the secret we didn't know. And no wonder, allow me inform all of you, this must be the reason why NCDs are escalating, because the lab were not there. We can't do the early detection. That's why I want to thank Wambale, who, actually, when I read through your abstract, I couldn't wait since yesterday to hear your presentation. So allow me call upon the entire laboratory fraternity. Let us work harder. We work together, like how we have made it in HIV. I think we can even do better, given all the skills we have. True or false? So where we are, it is very true we have challenges of supplies. That in the country, it is really a challenge. We are calling on all the partners to come and support us. We want cervical cancer can be screened right from your house. And actually, we want to thank still Ministry of Health. We had a pilot led by Dr. Nabadda. It is the pilot which integrated HPV testing into cervical cancer screening as a primary screening test. Don't you think, lab, we have a lot we can do? So I'm calling upon all my colleagues in the lab. Let us embrace, we use all the platforms we have. We are calling on the manufacturers, please, the scientists. We are the ones. Let us innovate as many screening kits as possible. Currently at CPHL, we are already testing for the leukemias using flow cytometry. And it's, I think we are the ones, and our fellow lab in Kenya for flow cytometry. They are the two labs in East Africa. And that one is going on successfully. We are detecting leukemias. And leukemias are also becoming so rampant. The same thing to the genomic sequencing of the EBV virus. At CPHL, that project has also just started. So, the laboratory, we have a lot of work to do. So I'm calling upon all of you to let us work together and we stand up. So I'm also very privileged to inform you that this year we have been given, Uganda, we have been given a mandate to support and host the African Test and Treat Initiative Conference, which is going to mark the World Cancer Day of 2023. Are we together? And actually, when we got it for us, this time the theme is on early detection and diagnosis to prevent cancer, as we prevent progression to the advanced cancers. We don't want anyone to end up at UCI. You rather go to your facility and go home. So I'm welcoming all of you. In case you get an invite, let's work together. We were the ones who were missing in the equation as the laboratory. And don't forget that quality assurance is our key role. So HuQAS, we appreciate you very much. Our key role as lab is mainly and strictly quality assurance. So I'm calling upon all the stakeholders, HuQAS, everyone, all the manufacturers, let us work together and we obtain a cancer-free world. Thank you very much.
Wow, a round of applause.